Hello, and welcome to today's university-based Child and Family Policy Consortium webinar. My name is Anna Kimura, and I am the Policy Assistant at the Society for Research in Child Development and the Consortium Coordinator. We're excited to welcome you today to today's webinar, Partnering to Serve Pregnant and Parenting Youth in Foster Care, Lessons from an Illinois Pilot Webinar. Before I turn things over to our speakers, I would like to say a few words about the consortium and about using GoToWebinar. Next slide, please. The university-based Child and Family Policy Consortium is a network of more than 25 university-based institutions, including centers, schools, departments, and programs that have an interest in child and family policy. We are organized about three main purposes. First, to share the latest findings and strategies for conducting policy-relevant research and to facilitate collaboration across our member institutions. Second, to encourage cross-disciplinary undergraduate and graduate training to support the next generation of child and family policy researchers. And third, to foster effective translation between research, practice, and policy audiences. The consortium is run in collaboration with the Society for Research in Child Development and hosts a number of webinars each year on a variety of topics. If you're interested in learning more about the consortium, having your institution join the consortium, or if you would like to join our listserv, please see the information on this slide. Just a quick word before we begin about the technology we are using today. We are using GoToWebinar to host this webinar. All of the attendees are muted and handouts are available to download from the sidebar. If you have questions for the speakers, please use the question box on your screen to submit them, and we will try to get to as many questions as possible at the end. In addition, today's webinar is being recorded. After it ends, the webinar will be uploaded to SRCD's YouTube channel, and we will share the link with all registrants. Please feel free to share the link widely as well. Next slide, please. Next, I am pleased to introduce today's speakers. Our first speaker today will be Jaime Russell, who received a master's degree from Illinois State University in social work and is a program director with Children's Home and Aid. Jaime has 15 years experience working with families in a variety of settings. She has spent much of her career in Healthy Families and Parents as Teachers program models and is a national peer reviewer for Healthy Families America. Jaime is currently working with Illinois M.S.W to increase home visiting services to youth in care who are pregnant and/or parenting. Our second speaker will be Dr. Amy Dworsky, who is a research fellow at Chapin Hall at the University of Chicago. Her research focuses on pregnant and parenting youth in foster care, youth who age out of foster care, and youth experiencing homelessness. She was the principal investigator for the Illinois Pregnant and Parenting Youth in Foster Care Home Visiting Pilot. Thank you both for taking the time to speak with us today. And now I would like to turn things over to Jaime to begin the presentation.
Hello, and thank you for joining us today as we talk about a pilot we had the pleasure of working on together over the last few years that worked to link pregnant and parenting youth in foster care to voluntary home visiting in Illinois. Next slide. We had many collaborative partners during this pilot, many of which we will reference throughout our presentation. Some of them were Healthy Families Illinois providers, Illinois Department of Children and Family Services, UCAN's Teen Parent Service Network, Erickson Institute, who provided our Fussy Baby fan, Chapin Hall at the University of Chicago, the researching team, Governor's Office of Early Childhood Development, who funds the M.S.W pilot, Children's Home and Aid, and the Illinois Home Visiting Task Force. Next page. First, we wanted to share some context for how this pilot came about. Next slide. A little history of home visiting in Illinois. Illinois has a rich history of investing in evidence-based home visiting programs and is a national leader in developing statewide systems. A strategic advisory board was created about 10 years ago that holds both public and private partnerships with an overall focus on improving quality and effectiveness within home visiting. This board is called the Home Visiting Task Force. Within the Home Visiting Task Force, many innovations in committees have been created and discussed over those 10 years. Illinois Pregnant and Parenting Youth in Care, which we lovingly dub IPIC, was one of those innovations. Around the same time that IPIC was starting, the task force was also looking at home visiting with homeless families and Illinois Family Connects. The Home Visiting Task Force established a subcommittee to manage the implementation of the IPIC work. This subcommittee was created and helped us to create the goals, objectives, the representatives we needed for the pilot, and all of that to take on this innovation. Next slide. Something highly unique about Illinois is we have a lead agency that is responsible for monitoring all pregnant and parenting youth in care. This agency that holds this contract is UCAN's Teen Parent Service Network. We'll refer to the agency as TPSN throughout this presentation. A major role of UCAN's TPSN is to monitor the collection of case management, placement, and parenting services for these youth. This came in response to a consent decree from a class action lawsuit filed against CCFS in 1998 called the Hill-Erickson Consent Decree. This consent decree defines the legal rights of pregnant and parenting youth in care in Illinois. Today, we're not going to go much into these services, but it's important to note that Illinois has a system in place where these youth are identified and monitored, and that UCAN's TPSN was an integral partner in this pilot. Next slide. So what was our overall motivation? Research shows that there's a high rate of pregnancy and early parenthood among youth in foster care, and that children born to youth in foster care are at a higher risk for maltreatment and foster care placement. Home visiting programs in Illinois have generally not served this population. There is not a clear understanding of why this is. However, this pilot was tasked to work on connecting these two entities. Next slide. So what were the goals of the pilot? The goals that were created were to provide pregnant parenting youth in care with access to voluntary home visiting services that would in turn promote parent-child relationships and healthy child development, would enhance functioning by reducing risk and building protective factors, and then again in turn would then break the intergenerational cycle of abuse, neglect, and trauma. Some additional tasks were to increase the coordination between child welfare and home visiting systems in Illinois, and to create a replicable model for providing home visiting services to pregnant and parenting youth in care. Next slide. So next we are going to talk about some of the overall pilot components. Next slide. First is Healthy Families Illinois. Healthy Families is a voluntary home visiting program that works with families to strengthen the parent-child relationship, model positive parenting, and promote healthy development and safety. As you can see, many of those were the overall pilot goals. It was an easy pick for being one of our components. Illinois has many Healthy Families programs across the state, which is another major point. Next slide. However, one barrier that arose when looking at home visiting models in Illinois was that Healthy Families programs require that families open into services prenatally or very early after giving birth. TPSN identified this as a potential issue due to many youth in care may not agree to services as early as Healthy Families program may require for many reasons. So the pilot reached out to Healthy Families America, the national model, about this potential roadblock. And Healthy Families granted the pilot a waiver that allowed pilot families to enroll up until the child's first birthday. Because of this waiver, the Healthy Families sites that the pilot had reached out to about being a part of the pilot participated and agreed to be in the research. Next slide. Another reason that Healthy Families programs were originally targeted was because of a high percentage of Healthy Families programs in Illinois have a doula component embedded into their program. It is not a requirement of the model. However, it is an additional enhancement that many programs have incorporated. TPSN felt that doulas would be a major selling point for these youth in a unique way to connect to a program that focuses on them and their pregnancy. For those of you who do not know what a doula is, it is a home visitor who helps prepare the mom and support systems for labor and delivery. They provide non-medical support and provide prenatal and postpartum education and breastfeeding support to the family. Home visiting doulas typically start with the family around the beginning of the 3rd trimester and transition out around 6 to 8 weeks postpartum. The doulas within home visiting programs come with no cost to the family. They are part of the long-term home visiting programs. Next slide. An important fact to know is that all of our home visiting programs volunteered to be part of the pilot and were not paid for the collaboration or extra work. One incentive that the pilot was able to provide to home visiting sites were additional home or infant mental health consultation hours. Illinois is lucky to have a robust infant mental health collaboration embedded into a majority of its home visiting contracts across the state. Programs use infant mental health consultants to enhance supervision, group learning, and trainings. The pilot felt it was important to embed additional infant mental health hours into programs to support the work of opening families identified through the child welfare system. Next slide. I will quickly mention that the pilot team held 3 cross trainings throughout the state with the intention of building understanding between the home visiting and child welfare work. In all 3 locations, the trainings were attended overwhelmingly by home visiting program representatives. Next slide. This slide is to show that throughout Illinois, the Healthy Families programs, where they were located. The only difference in the 2 colors of circles is that the purple circles were where the majority of the IPIC families were opened. The blue circles were where sites agreed to have IPIC families, but might not have received any or very few referrals during the pilot. Next slide. Eligibility into the pilot. The youth needed to live in a zip code by one of the Healthy Families providers. They needed to be pregnant or parenting a child under the age of 1 at the time of enrollment, needed to be a youth in care themselves, needed to agree to services, and not already receiving a duplicative service, which the pilot team was able to determine through TPSN's database prior to even offering the services. So once the youth was identified through TPSN as fitting those criteria, the TPSN engagement worker would call the family and talk with them about home visiting. If and when the youth agreed to hear more about home visiting and a consent was given, TPSN would get a referral, it would get the referral to me as the pilot manager, and I would work with the home visiting programs to start outreach. Next slide. A major component behind the scenes was the pilot team doing continuous quality improvement work. The pilot team had weekly conference calls to identify potential families and discuss open families. During these calls, we would look at some of the data coming in from sites and also work to answer questions that sites might have. An example of some questions were they would request case manager contact information or would ask for us to look into the data system to see if a youth was on run, if they weren't able to be in contact with them and such. We also held 2 IPIC days where we invited all the programs together along with TPSN and Chapin Hall to talk about the successes, the lessons learned, and what sites are needing more or less from this pilot. Additionally, we created a tip sheet to help sites navigate questions they may have. Contact pilot manager for certain types of questions and then also how to contact TPSN if they had questions about being on run. And then finally also how to contact Chapin Hall if they had any data related questions. Finally, we had quarterly subcommittee meetings to inform our task force committee of where the pilot was and to seek guidance for next steps as we continue to move this work forward. Now I'm going to pass it on to Amy Dworsky to talk about the actual evaluation results and findings.
Thanks, Jamie. So I'm going to talk about the evaluation. What I want to say at the outset is that the purpose of the evaluation was not really to assess whether home visiting services were improving the outcomes of young parents and their children. It was more of an implementation evaluation to see if home visiting services could actually be provided to this population, what the barriers to providing those services were, and how we might improve the provision of services moving forward. We had data from a number of different sources as part of the evaluation. We collected a data, we created a data collection tool that was used by the home visitors and doulas to enter information about every home visit that they had with pilot clients, including visits that were missed. So they entered information about the types of activities they engaged in with clients, the types of referrals they may have made, as well as information about things like child immunizations, well child checks, prenatal care, all things that would be discussed during a typical home visit. We also conducted in-depth interviews with home visitors, doulas, and supervisors. And we conducted in-depth interviews with 29 young parents who participated in the pilot. Finally, we analyzed DCFS administrative data to look at the foster care placement histories of the young parents who were in the pilot, as well as child maltreatment investigations involving their children. Next slide. So here's a little bit of information about the pilot participants. We had 43 young women who enrolled in the pilot between November 2016 and December 2018. Although the pilot was technically open to fathers, we did not actually enroll any fathers in the pilot during those months. The average age of clients at enrollment was 18.3 years old. 27 of the clients were pregnant at the time they enrolled. The remainder were already parents. The median days enrolled was 362, which obviously means that the youth were typically enrolled in the pilot for about 1 year. 18 of the young people received doula services while they were enrolled. We had 972 completed home visits out of a total of 1,468 visits that were either completed or attempted. And that's, if you do the math, that turns out to be a 66% completion rate, which is actually pretty good, especially for this population and some of the challenges that we'll talk about later. Next slide. I'm going to talk through a number of the major themes that came up primarily in our interviews with the young parents and with the home visitors and doulas who were serving them. Next slide. So many factors influence the decision of young people to engage in home visiting services. And I'm going to talk about several of these. Number one was choice. Most of these young people had been in the child welfare system where decisions were made for them. They were not usually given an opportunity to decide what services they wanted to participate in. So having the ability to say yes or no when they were given the option of participating in home visiting services was very important. Confidentiality was also important. They appreciated knowing that what they told their home visitors would stay with their home visitors. Exceptions were made, of course, for mandated reporting issues, but other than that, they felt free to talk to their home visitors about issues that were of concern to them. They also valued the fact that their home visitors could be depended upon. If their home visitor said she would be there on Monday afternoon, she was there on Monday afternoon. Again, this is something that they didn't always experience with prior service providers. Young parents also recognized that they needed some sort of parenting education. We often heard from the young parents that they recognized that there were certain things about caring for a young child that they didn't feel prepared to do it. And they had many questions about what was best for their babies. And finally, young people also had an incentive to participate. Many of the home visiting programs provided baby items, bottles, diapers, things like that. And young parents saw that as an additional incentive to participate in the program. Next slide. Building a trusting relationship between the home visitors and the young people who were receiving services was a challenge, but it turned out to be very important. The pregnant and parenting youth in the pilot, oops. The pregnant parenting youth in the pilot developed strong relationships with their home visitors and doulas. They came to trust their home visitors and doulas more than the other professionals they had worked with, such as their caseworkers or their therapists. And this was actually something that they told us again and again. At the same time, the home visitors and doulas also believed that the pregnant and parenting youth benefited from having supports outside of the child welfare system. So the young people could understood the difference between their home visitor and, say, their caseworker or their therapist, who they saw more as part of the child welfare system. Next slide. So here are two quotes. The first one is from a young parent. She said, "I'm not the type of person that when I meet someone, I feel like I can trust them and talk to them. With my doula and home visitor, it was just different. I felt like they understood me." So again, this is that difference that they were drawing between their home visitor or doula and other professionals that had been in a helping role, but who they associated with the child welfare system. And then we heard from a home visitor who said, "I think these girls have a general distrust of others and of the systems and people who are there to support them. People that were supposed to be there to support them were not, and they're kind of expecting me to do the same. After working with them for a few months, I'm starting to get through for them to trust me a little more. I feel like I'm always being tested with all the cancellations." So again, this is that issue of the importance of building that trusting relationship, but the challenges in doing so. Next slide. One of the things that became clear from, particularly from the interviews with the home visitors and the doulas, was the fact that many of the young people participating in the pilot lacked a natural support system. And the home visitors and doulas often found themselves stepping into those roles that a natural support system otherwise would. And then on the next slide, you'll see a quote that really drives this point home. Next slide, please. So the first quote is from a home visitor. She said, "If other clients," meaning her other clients, "had questions, they might just ask their mom, their grandma, or a friend. But I was that person her pilot client would call or text and ask those questions to." So again, the pilot client she's thinking of didn't have a natural support system, so the home visitor ended up filling that gap. And then the next two quotes are actually from pilot clients. One said, "I could tell her I was going through stuff. I texted her any time of the night. She would respond and call or talk to me, tell me everything would be okay." And then the other client said, "My home visitor kind of became a mother figure because I don't have a lot of those. I don't have any of those." So these young people recognized that they didn't really have many people that they could turn to for support or to ask questions or to talk with about their concerns, and they were turning to their home visitor or doula to fill that gap. Next slide, please. So we heard a little bit. We heard a lot from the pilot clients about how they saw themselves benefiting from the services. So the pilot clients talked about learning about childbirth, learning about child development, learning parenting. They also developed coping skills, particularly around coping with anger and frustration, for example, when their baby wouldn't stop crying. And they also developed more positive relationships with their baby's father. So although we didn't have any dads enrolled in the pilot per se, in a number of cases, the father of the baby was actually participating in services when the home visitor came to the home. He would sit in during those sessions and talk with the home visitor and also learn along with the mother of the child. Next slide. So here's a quote from a home visitor talking about how she saw one of her pilot clients benefiting. "She would ask me different ways to do tummy time because she had concerns about the baby dropping her head on the floor and hurting herself. She's been thinking about all these things and wanting to protect and keep her baby safe. She was looking for more ways to help strengthen her baby's neck and some other activities to do with her." So this is the home visitor describing how she saw her client benefiting from the services. And we heard similar stories from some of the other home visitors and doulas we talked to, that they saw ways that the clients they were visiting were really learning about things that they could do with their children to enhance their development, to keep their children safe. And if they may have had concerns about things, they were raising them with their home visitors and thereby becoming better parents. Next slide. So as we mentioned, I think early on, one of serving this population is a challenge, and that may explain one of the reasons why home visiting programs, at least in Illinois, have not traditionally served these clients. So we're going to talk about some of the challenges that this presents. So one that Jaime alluded to was young people experiencing multiple placement changes. So often while they were involved with home visiting, they would be moved from one foster home to another, or moved from a group home to another. And this created a challenge, particularly when the one placement was in the catchment area of one provider, and then they were moved to a placement that was in either a catchment area of a different home visiting service provider, or in a catchment, or in a place where there was no provider associated with the pilot. And so we had to find ways to deal with those cases. And sometimes we were able to make a transfer from agency A to agency B, which went more or less smoothly depending on the agencies involved. In some cases, we were able to find a home visiting program that was not involved in the pilot who would be willing to take on this case. And in some cases, unfortunately, young people were moved to areas where there was no home visiting program that was able to serve the young person. And so in those situations, we would do the best we could to connect them with other potential services. But this just proved to be, this was a real challenge with serving this population. Another challenge was the fact that young people were frequently AWOL from their placement. So young people would often run away for, could be just a day, it could be a week, it could be a month, it varied. And sometimes while they were on run, they were in communication with their home visitor, and sometimes they weren't. And so that was one of the functions of those weekly calls that Jaime talked about, was sometimes to find out, is this young person on run? Do we know where she might be? What information can we provide to the home visiting agency? So that was something that home visiting agencies do not typically deal with their clients, and so this was something that was new to them. We had a number of young people who were hospitalized or spent time in detention during the pilot. Again, this was an interruption to service delivery in some cases. And sometimes the home visiting programs did not know where their client had gone. They would go out to do their weekly or biweekly visit, and no one would be there, and they wouldn't know why. And so this was another thing that we did during those weekly meetings, was to determine, is this young person in detention? Is she hospitalized? And again, let the program know why they were not able to get in touch with their client. And then finally, which I already alluded to, this issue of clients moving or being moved outside the catchment areas. Sometimes this happened in relationship to placement changes. Sometimes it happened when young people left care. So we had a few young people who aged out during the pilot period. The home visiting programs would continue to serve those young people after they aged out of care. But in some cases, the young people moved as part of aging out, and sometimes that it was just not possible for the program to continue serving them. So I'm going to show you 2 slides now just to illustrate the extent of the placement change that I talked about. So the first slide it shows you pilot clients who experienced 5 or fewer what we're calling events while they were enrolled in the pilot. The events could be a placement change, or they could be something like going on run, or being hospitalized, or being in detention. So each bar represents a pilot client, and the colors represent different types of events. So just for example, the top bar shows a client who experienced 2 events. So she was in one type of placement, and then she moved to another type of placement. So her experience in the program was relatively stable. The next client, the second highest bar, was in the same placement the entire time she was in the pilot. And the bottom, the x-axis at the bottom just shows you the number of days. So again, this is just during the period of time they were enrolled in the pilot. This is not their entire placement history. So these are those whose placement history was relatively stable. If you go to the next slide, this is the other extreme. So these are pilot clients who experienced 20 or more events while they were enrolled in the pilot. So these are young people who had a lot of placement changes, a lot of times running away or being hospitalized or being placed in detention. There's a lot of instability, and you can imagine the difficulty of trying to provide home visiting services to a client that's experiencing this much instability in her life, and in some cases in her child's life as well. And then we have a lot of clients who are in between these 2 extremes. But I think this really illustrates one of the big challenges of trying to serve this population. Next slide. As I mentioned, pilot clients also experienced a number of other kind of destabilizing events or crises, including detention, psychiatric hospitalizations, domestic violence, CPS hotline calls, and in a number of cases, actually having children removed by DCFS and placed in foster care. Next slide. One of the biggest challenges for the home visitors, in addition to dealing with all of the instability in their clients' lives, was trying to navigate the child welfare system. As Jaime mentioned, we did have those cross trainings before the pilot actually got started. But throughout the course of the pilot, a number of additional questions came up from the home visitors and doulas about the types of services and resources that are available to young people who are in care. They often had questions about their role in team meetings to which they were invited with other people that were involved in the young people's cases. They didn't always know what their role should be. Should they be there as an advocate for their client? Should they be there contributing to the case plan? You know, what role should they play? And then there was a number of challenges involved in serving clients who were in congregate care. We had one congregate care provider in particular where there was quite a few young people who were in the pilot, and working with that care provider was pretty challenging. They had very set schedules at the group care facility where these young people were living, which complicated trying to schedule visits. It also made it difficult for young people to have privacy because the care provider required that visits take place in a common room rather than in the client's own private bedrooms. And so working through some of those issues was a real challenge. I think over the course of the pilot, the relationship improved as the provider learned more about the program, and the program developed more rapport with the provider. And I think that it just took a lot of work, a lot more than we were expecting to make that possible. Next slide. We also had a number of questions that came up throughout the pilot about information sharing. So in particular, what types of information should child welfare workers share with the home visitors and doulas? So particularly information about youth being on run or youth being in the hospital or in detention. When should they share that information? And then conversely, what information can and should home visitors or doulas share with child welfare workers? They wanted to respect their clients' confidentiality, but at the same time, they wanted to be collaborative. So where do you draw the line? How much information did they feel comfortable sharing? And what type of information? What information did they feel they needed the client's permission to share? So these are all issues that still need to be, I think, grappled with as home visiting programs and child welfare systems work more together. Next slide. Here's a quote from one of the home visitors about information sharing. We kind of struggle with, like, is there a benefit from us knowing it's that relationship? If they turn to us, they're going to turn to us because they need more of the emotional support and a safe person to talk to. And what this home visitor is referring to is at the beginning of the pilot, there was some thought that maybe the home visitors wanted to know about the young person's foster care history and the types of issues that brought them into care and what their placements had been like. But over time, they kind of decided that they really didn't need that information. If the young person wanted to share it, great. If they didn't want to share it, that was fine. They were more focused on the relationship building here and now rather than what had happened to the young person in the past. Next slide. There was some variation across the 9 different HFI providers that were involved in the pilot in terms of their ability to work with pregnant and parenting youth in care. We had a state budget impasse for a couple of years that really affected some programs more than others. Some programs had to lay off a number of staff, and it just really impacted their ability to serve the population. And then programs also varied in their willingness to accommodate the needs of pregnant and parenting youth. So some programs were very generous and would do what they could to keep cases open even when young people were consistently missing appointments. Other programs kind of kept to a hard, fast rule that 3 missed visits and we'll close the case. So programs really kind of varied in their willingness to make adjustments to work with this population. Next slide. Maintaining fidelity to the HFI model was a challenge. HFI has levels that kind of dictate how frequently clients should be seen, whether that's every week or every other week or once a month. And those levels did not necessarily reflect the amount of effort taken to serve this population. The visits with this population were sometimes less frequent or shorter than the model prescribed. So rather than an hour or 90-minute visit, sometimes the visits would only be 30 minutes, for example. That was an issue at the congregate care facilities. Sometimes there was less time to cover the standard curriculum that the programs use because clients were dealing with all those crises that we talked about. And then finally, the model is just really not designed for parents whose children are not in their care, particularly for long periods of time. And as I said, we had a number of clients where their children were placed in foster care, not just for a couple of weeks, but for an extended period of time. And trying to figure out how to deal with those cases was something that the programs had to adapt to. Next slide. And then finally, just want to mention a few things where the home visitors and doulas really went above and beyond the call of duty. We had a home visitor who transported her client who was enrolled in college to and from a crisis nursery every day at the end of her semester so she could just get through that semester of college. We had home visitors who were attending supervised parent-child visits for a child who was placed in foster care so she could continue to work with the parent and observe the parent with the child. We had one program that wanted to give its clients at the group care facility with the same opportunities that their other clients had. So they brought their childbirth and parenting classes, and they brought their mobile pantry to the residential care facility rather than because the clients could not actually get to their agency to take part with those benefits. We had a home visitor who consistently went to the juvenile detention facility to visit with her client. We had another who drove several hours each way to visit with a client who had been placed in a residential care facility way out of the catchment area. And then we heard a really nice story at one of the IPIC days about a home visitor who, as client was having a job interview, the home visitor got her address. She took her to the job interview. She babysat her baby while the mother was in doing the interview. And then fortunately, the mother got the job and it worked out really well. So it was a happy ending. Next slide. And then the importance of providing home visitors with supports was also clear. As Jaime mentioned, all of the programs in the pilot got enhanced infant mental health consultation. And one home visitor talked about why she needed that. She said, I was getting emotionally overwhelmed just hearing her story, hearing her struggle and her mom's struggle and how history is repeating itself. The infant mental health consultant was very helpful in helping me see things a little differently in a more hopeful way. Next slide. So Jamie's now going to talk about implications and next steps.
Okay, thank you. Next slide. Now that we are done with the research piece of it for the pilot, we are really working on moving from what I just referenced as pilot to normal practice throughout Illinois. And so different ways that we're looking at doing a statewide implementation is first adding sites, particularly in southern Illinois. As you saw the map earlier, a lot of the sites that we had were in our northern area, as well as a few in the central, but not so much in our southern region. So that's something that we absolutely know is an area that needs to be addressed, and to look more into our southern Illinois to add sites. Not only sites, but we also are looking to add new program models. Not all families in the youth and care population, pregnant parenting youth and care, will fit into Healthy Families America criteria. And Illinois is so robust with home visiting programs. As Amy had mentioned, that not all home visiting sites can necessarily accommodate the needs of what we see as resources that pregnant parenting youth and care might need, or they may not have the ability or willingness to adjust to make those adjustments. And so we want to make sure that we are looking at home visiting models across the state, and that are across program models as well. Parents as teachers, healthy families, nurse-friendly partnership, baby talk, just any type of home visiting program that has a desire and has training and all that to be able to open up and meet the needs of these families. We are working with statewide coordinated intake. So coordinated intake is another McV innovation that we are working to increase in Illinois, to where we have single points of entry in different areas across the state to get different types of services, including home visiting. And so the team is working to go to the different coordinated intake entities and talk with the teams, the home visiting programs there, just to talk about working with youth and care who are pregnant and parenting, and seeing what different training needs or questions they may have to be able to open that. We have recently been working with a coordinated intake site out of Cook County, which is the Chicago area, and just this month we're able to link for pregnant parenting youth and care into that just through coordinated intake. So that's definitely a resource that we are working with at this time. Eventually, we're going to be working to serve intact families, so families that have been identified through the child welfare system as needing additional services, but are not necessarily, the child's not necessarily removed from their care. And we are hoping that the lessons learned through the pilot that we're able to kind of replicate these type of services to other child welfare involved families. We are looking to address our training needs, both on the home visiting side, as Amy and I have both talked about all of the different questions that have come up for home visiting programs around what families may experience that are going through the child welfare or that are starting to age out and emancipate from being a youth in care. And so those are all different topics that home visiting programs don't tend to get training on. And so there was a lot of questions around what families may experience going through the child welfare system that home visitors can help walk them through and understand, as well as really working also on the child welfare side of training child welfare on what home visiting is and what they can provide and what roles that they can bring to a family's life. We are working to develop information sharing policy. Again, mentioned earlier that a big question that continues to come out through the pilot was, what is okay to share? Do I have to report certain things back? So being more intentional about developing a policy that is both okay for on the prevention side and the child welfare side. We've heard both sides say they would need certain information or they're not comfortable sharing certain information. And so really making sure that the child welfare side and the home visiting side feel comfortable in what is appropriate to share while working collaboratively together for a family. And finally, we're working to establish infrastructure for monitoring troubleshooting. We did a lot of that through the pilot stage, but as we grow bigger and look at this more statewide, we need to continue to have an infrastructure that is monitoring this and that we can put in troubleshooting measures as it comes up, and it's not just something that gets lost in the shuffle moving forward. Next slide. We wanted to briefly mention how the Family First Prevention Services Act can go into this as well. We're using in Illinois the lessons learned from the pilot to inform Family First implementation. Family First is where states can use Title IV funds to provide in-home parent skill-based programs rated well supported, or promising by the clearinghouse. At this time, 3 home visiting models have been rated well supported, and those 3 are Healthy Families, Parents as Teachers, and Nurse-Family Partnership. And these services can be provided to children who are candidates for foster care, for parents and caregivers of those children, and most significantly for this pilot, pregnant and parenting youth in foster care. So we're very lucky to have the different research and the pilot results and lessons learned from this to be able to help implement this going forward in Illinois as well. Next slide. So we wanted to give some time at the end to do any questions that may come from this conversation. We did have some submitted previous that I'll read, and Amy and I will try and answer the best as we can, knowing that not all of these questions are ones that we may know exactly the answer to, but we'll try and at least steer people in the right direction. So the first question was, what resources are available if the recipient is about to age out of the system? Are there sustainable measures in place?
So I can start, Jaime. So one thing we said is that the home visiting services actually do continue. When the young person ages out, they stay eligible for home visiting services until their child, I believe, is 3 years old. Jaime, is that right?
3 to 5, depending on the program.
Right. So yes, so they continue to receive those services. The Department of Children and Family Services in Illinois also has a number of other services for which young people may be eligible, depending on the situation when they age out, depending on their age. There's a housing advocacy program that will help young people find housing. Some young people are eligible for family unification vouchers, which are basically Section 8 vouchers that they can use to help them pay for their housing. Some young people are eligible for various education benefits, such as the Education and Training Voucher Program, which provides educational assistance for post-secondary education and training. So it really depends on the situation of the young person, what they're eligible for. So it's a little hard to make general statements, but and then in Illinois, there's also an emancipation fund for youth when they age out. If you jump through a couple of hoops while they're in care, they receive an emancipation fund, basically that they can use to help them sort of bridge that gap from when they age out to, for example, when they have a job or another source of income. So it really depends on the young person's situation, but there are a number of different programs and services available.
Okay. One that just came through, when will home visiting be offered to all pregnant and parenting youth? Will it become an expectation for those parents? One thing we wanted to be mindful of with this pilot and going forward is that home visiting is a voluntary service, and we know that this population or populations within child welfare do not typically have the capacity to say no, or the ability to say no to a service. And so we, when it is offered and discussed with the family, it is discussed as a voluntary service, that there's no penalty for a family, whether they decide to join, or if after they get in the program for a little while and realize it's not for them, if they exit the program. We do not want home visiting to be seen as a resource or a program that a family has to complete or be graded upon. Something we are working on with Family First legislation and things is really advocating for the child welfare side to not have home visiting placed on any type of service plan for a family, because then that comes with requirements that they check in, or they get kind of graded upon how they're doing or how often they're meeting, and that's not the value behind home visiting programs. And so it has not become an expectation for those parents. And the other part, when will home visiting be offered? It's offered, we're trying to do right at the beginning, once the family becomes announces they're pregnant or comes into TPSN already having a child, that it is discussed. And it is offered to them in a way that says, are you interested in hearing more about it? And then the home visiting program themselves would be the one to come and sell their program and what services they're able to offer for each individual program. Another question that came in, any lessons related to current placement settings or creating housing pathways for these young parents to prevent homelessness?
I think that's a little difficult because it wasn't really the focus of our evaluation. We do know that homelessness is a major problem among young people aging out of foster care. I don't know that it's that the pilot really provides any lessons about addressing that problem in any particular way. Other than the fact, I think the only issue that we saw related to housing was some young people were choosing to move away from where they had been getting home visiting services because they saw more housing opportunities in other communities. So, for example, I think I mentioned the FUP program. So I think in at least one or two cases, we had young people who had an opportunity, for example, to get either a Section 8 voucher or public housing or some other type of housing assistance in another community. And so they made a decision to leave, for example, maybe the Chicago area, which unfortunately meant disconnecting them from their home visiting services. So I think that just really drives home the point in the importance of getting these services available statewide so young people don't have to choose between housing and home visiting.
Thank you. Time for one more. How does this program integrate with programs or trainings for foster parents in the same geographic area? This program has not really integrated with that at this time. I think as we move on to working with more in depth through the Family First legislation, at least in Illinois, one thing we will be looking at is opening up home visiting services to potentially to, as we talked, to intact families, possibly foster care families, families that may be fostering young children would be a great candidate for having home visiting as well. So I think in the future, home visiting can really kind of integrate with these a lot. We have not gotten to that point, at least through this pilot as of now, but it is definitely on the horizon as we continue to what we call build our bridge in Illinois between the child welfare and the prevention side that we will look more into and hopefully be able to provide more collaborative services between those two. I believe we are out of time. I want to throw it back to our hosts to wrap up, and we thank you guys for joining the webinar today.
Thank you so much, and thank you to everyone who joined us today for this webinar. It was a really wonderful presentation. If you like today's webinar, you may be interested in future consortium webinars in the 2019-2020 academic year. Please see the information on this slide if you're interested in helping to plan a webinar in the upcoming year, or if you would like to join the consortium listserv to receive notifications about future webinars, a quarterly newsletter, as well as other job and event announcements. In my follow-up email, I will attach a copy of today's slides and a link to today's webinar, which will be posted to SRCD's YouTube channel. Thank you again to everyone for joining us, and we hope you have a great rest of the day.